Aloy Majumdar, who will be speaking on OCT and biomarkers and inflammation in diabetic cystoid macular edema.
Hello, good afternoon. My thanks to the scientific committee for giving this an opportunity. And I will be talking on the biomarkers of OCT and the inflammatory components of diabetic macular edema. I have no financial disclosures. So these are the various inflammatory biomarkers, and if you pay attention, you'll see that the most of them are the inflammatory biomarkers which are more important. So this is the main cause of diabetic macular edema. Now these is the cascade of the various levels of involvement of the different biomarkers and the inflammatory chemicals, and most of them are the inflammatory cytokines which play a major role in the initiation, development, and the progression of diabetic macular edema, and thus dictate the response to your treatment. So OCT enables a layer-by-layer analysis of the characterization of retinal pathology, and there are three pertinent questions that are raised. Number one, is it easy to find these biomarkers in the OCT? Do these influence the management? And number three, do they help in prognostication of your case? So the biomarkers are usually divided into the ERM, the DRIL, the inflammatory hyperreflective dot echoes, the SRF, the increased fundus autofluorescence, choroidal thickness, and choroidal vascularity index, out of which the increased choroidal autofluorescence is not much of an OCT finding. It's more of an angiographic finding and the fundus finding. So this is a case of the vitreomacular traction. You see the ERM with the CSME with the ERM. We don't have any traction on 3D viewing. So the question is whether the anti-VEGF will be effective. So that's how it works. After 3 anti-VEGF injections, it works. Because there was no traction, you don't see any significant biomarkers except a few hard exudates, which are not actually inflammatory biomarkers. The swelling has gone down after a PPV and after the removal of the epiretinal membrane. Now here is another significant vitreoretinal traction, the DRIL. Now this is a predictor of the final visual acuity in the cases of CI-DME. The early change prospectively identifies the eyes with high likelihood of subsequent visual improvement or decline. OCT-A also indicates a loss of blood flow and retinal ischemia corresponding to the DRIL, and it works as a robust biomarker. So this is a patient, a female patient for 58 years, type 2 diabetes, hemoglobin A1C 10.6, and you can see the DRIL, and it correlates with the visual acuity in center involving DME, and it's strongly associated with the disruption of ELM, ellipsoid zone layers, and the presence of epiretinal membrane. Now this is a case of localized DRIL. So if you see there's a localized area. Do I have the pointer? Does it work? Works? No. Works? So here's the area. Oh yeah. So here's the area of localized DRIL. You can see the hard exudates giving the after shadows, and here's the localized DRIL. Now this is the DRIL. Again, another case of DRIL. You can see the outer retinal layers getting disrupted from here to here. Now the next important biomarker which has come up in the recent times is the hyperreflective dot echoes and the foci. There are small hyperreflective dots, as you see, and to differentiate with the hard exudates, you see that hard exudates are significant enough to put an after shadow, but these dots, they are not putting any after shadow. And that's the important feature to differentiate between the two features. There's another case in which you see the SRF, the DRIL, hardly any DRIL, but a lot of biomarker hyperreflective foci and the hard exudates. And the BCVA improved after anti-VEGF. There's another case of a CME with HRE foci. So the number of hyperreflective dot foci are a predictive indicator, and these patients respond better to the steroids as compared to the anti-VEGFs. This is a case, a mixed case of HRD with hard exudates and DRIL. There's another case of a drawl with a DRIL with hyperreflective foci. And here's a subretinal neurosensory detachment. And this is because of the microglial cell attraction and impaired choroidal blood flow. This is, has been found at a higher concentration of inflammatory cytokines, interleukin-6 in these cases. So this is another mixed case, SRF, which hyperreflective dots with a BCVA of 2/60, which improved after Ozurdex injection to BCVA 636, and we see the response to the biomarkers. Now, the choroidal thickness has come recently from SNAC, and a lot of work is going on, and it is still due to be evaluated how much is the effect of the choroidal vascularity index. The subfoveal choroidal thickness is obtained using SD-OCTs, and they are converted into scans of 8-bit, followed by NIBAC auto local thresholding to enhance, and then using a color threshold tool, the dark pixels represent the luminal areas, and the light pixels, the stromal areas. These are the various features. This is a regular SD-OCT converted into with the NIBAC conversion system. There's a CSME, and you see how the choroidal vascularity is being assessed. This is the luminal areas, and these are the core stromal areas. This is the case of subretinal neurosensory detachment. So the three pertinent questions that we started with: is it easy to pick up these biomarkers? If you look well, give time to your OCTs, yes.
Time is up, sir.
Do these biomarkers influence your management of DME? Yes. You have more of biomarkers. You can always think about the steroids as the first line if you have a pseudophakic patient. So do they help in prognostication? Yes. If the inflammatory biomarkers are there, suppressing the inflammatory input will definitely work better than looking only at the anti-VEGFs. Thank you.
Thank you, Dr. Majumdar. You have magnified our view of our OCT. Now we invite Dr. Sandeep Saxena, who will be focusing on ellipsoidal zone